For the case 1, if you see the diagnosis is oculocutaneous albinism, 3-year-old boy, and about 10 years ago was his first visit. And when the binocular acuity was recorded, 20/600 using Leah symbols, matching acuity was done. And this was the present spectacle prescription. Okay, so and this is what is dry refraction value that you are seeing, plus 4.5 diopter cylindrical at 100 axis, and similarly in the left eye plus 4.5 diopter cylindrical axis 80. And these are cycloplegic refractions that you are seeing here. Here in subjective was not possible at 3 years of age, so check the subjective response there. So but cycloplegic refraction, if you see, it's almost similar, confirming that about 4 diopter of cylinder with the rule, and 4.5 diopter of spherical value, and these were the values prescribed. Okay, about 1 diopter under correction from the cycloplegic net value. Is something bothersome here? Is something concerning here? Do you see a change or a difference in the present spectacle prescription? So the existing prescription and the new prescription, what do you see a change? Right. So in dry and cycloplegic, both the refraction values are showing high astigmatic correction, and something similar has been prescribed as well. Okay. And in this specific case, because subjective is difficult for you to perform and the child is just 3 years old, you know that, okay, subjective response gives so much of variability as well. So what was done was empirically looking at these two values, a prescription was designed. Now, what could be the thought process in the clinician's mind when they prescribed this prescription? And what do you expect it will result in, um, considering the now if you look at the values that person is already prescribed plus 6 that is there in the current spectacle prescription. So what will be important for you to understand is, like, if person, you have to check for the compliance from the parents, that whether child prefers keeping it or prefers seeing it without it, because the spherical equivalent which is being prescribed and what is person using, there is significant difference. Even cycloplegic refraction does not show that. So which means either the person who had done the previous refraction and prescribed it, what happened? So how old are these present spectacle prescription is something which somebody has to analyze. And whether it was based on the cycloplegic refraction, how come somebody missed that high astigmatic correction? And if it was originally like the initial, whether it was really spherical or just somebody has looked at the one meridian and ended up prescribing, did not look at the astigmatism. So whether it was missed in the first visit and how was the compliance, because if you see there's a significant change, and in 6 months how much change do we expect in refractive error, or in 1 year time how much change can I expect? So is it within the expected physiological change that we expect as per the age norm, or it is something which is unexpected? So those are the thought process which has to come in my mind, and then we should see that, okay, if my dry refraction value and cycloplegic refraction values are consistent, the only difference that you see here is, like, one is written in the plus cylinder form, other one is written minus cylinder form. People can transpose and then find it. So about 4.5 diopter of cylindrical error that you are seeing with the rule you are seeing, that is expected. So if you look at the literature suggests that in patients with albinism, moderate to high amount of astigmatism, 2.5 to 3 diopter or more cylinder is noticed. These are usually with the rule, these are usually corneal astigmatism. So once you prescribe early stage, this correction will prevent meridional amblyopia. If that astigmatic correction is not provided, just if you take care of the spherical equivalent or spherical values, it will not help the child develop the vision. So for that reason, that is important. But at the same time, some amount of undercorrection that has been considered is considering that about a diopter hypermetropia 1.5 diopter hypermetropia is physiological at that age. So even if you leave that under correction with their accommodation, there should not be problem, and then you are not interfering with the emetropization process. So for that sake, you are leaving slight under correction there. Okay, so those are the thought process with which this new spectacle prescription was designed. And see, the same person comes after 2.5 years for follow-up. And again, if you look at the dry refraction, subjective acceptance. So in 2.5 years means child is now 5.5 years. So with the prescription and trial frame, you can check how the acuity is improving. So earlier the binocular acuity was 20/600. Now monocular acuity is possible. It's recorded. You see the cycloplegic refraction is also done here. Now the values that you are observing here, the objective and subjective, dry and cycloplegic refraction. Take a minute or 30 seconds, process it. Do you notice any difference in the refractive status from the previous visit? Anything that is bothersome here? Visit? Cycloplegic refraction showed plus 4.5 with -4 cylinder, and left eye plus 4.5 with -4. So if you see, both are symmetrical. The amount of spherical, cylindrical are exactly same in the right eye and left eye. Here in you are observing, in the dry also, left eye shows more hypermetropia, and cycloplegic also shows more hypermetropia, about 2 diopter difference that you are seeing, and then person is accepting as well. So in acceptance also, that difference is being accepted. So what could be the reason here for this difference? Earlier it was symmetrical, now it is showing anisometropia, right? So why are we observing this difference, and how do we validate or confirm? Do we have any test that confirms us that, okay, this is our observation is correct? Or is it just the test retest variability? Can we perform some test in the clinic to validate this difference? So in these cases, when you observe these differences, if you get the A scan done, it will reflect you how much it is, the axial length difference, and how much is the K value difference that could account for this. Is it objectively the objective measurement that you have taken in retinoscopy, the subjective that you are seeing, is it true, or it is because of incomplete cycloplegia in one eye, or what is the underlying cause? So you have to have that thought process in your mind as a clinician, that what is the reason now, or is it abnormal growth of one eye versus the other, or the change the way in the development process, the corneal shape is changing, axial length is changing, the resultant values are different. So in this specific case, if you see, the A scan was done, so you see the axial anisometropia, you are seeing that which eye is shorter, left eye is shorter, right? Left eye is shorter, right eye is longer. So the shorter eye will have more hypermetropia. So left eye had more hypermetropia. And now the difference which you are seeing here is about 0.74 millimeter. And if you assume that each millimeter causes 3 diopter, it gives you 2.2 diopter difference. And that is what you're observing there in your refraction value as well. Similarly, if you look at the K values here are showing, if you look at the astigmatism at 14 degree, 5 diopter. Similarly, in the left eye, 5.65 diopter at 172. So which means it validates that, okay, corneal astigmatism exists, and it corresponds to something, what was your observation in your dry and cycloplegic refraction values, and that the difference that is observed is true difference. It is not because of incomplete cycloplegia or the measurement error. It's not that now there's a measurement error and then you should prescribe again symmetrical, because I see that at times when the students or some of the clinicians, even if they observe difference, they end up prescribing the symmetrical values. But then if you're prescribing symmetrical value, what happens is the accommodative demand is not symmetrical in both the eyes. Patient may often complain of eye strain and other things. And then if the eye which you are leaving it undercorrected hypermetropia, that eye may develop amblyopia or may have risk of amblyopia. So it's important to, if you are undercorrecting, undercorrects proportionately so that both the eyes get equal clarity or equal defocus, and then develop normally. So if you see what happened in another 3.5 years when person comes back for follow-up, you look at the acuity. The eye which has more hypermetropia actually has done well in terms of acuity development. So initial visit it was 20 by 600, then 250. Now if you see it is 160, so it's more than 2 line improvement there. And significant improvement is there. If you see the refraction values, you are seeing that yes, it is something similar. It is shown here in the dry and cycloplegic refraction values. So two diopter anisometropia exists. The cylindrical axis, which you are seeing, is about 5 diopter, which somebody has obtained it here. And based on this, person was given prescription so that further improvement takes place in this child. Test retest variability. So through this case, what we learn is retest variability can happen. We have to find out what could be the possible reasons, validate it, and in some cases, if subjective refraction is so difficult, you can do objective assessment using the A scan, using the topography, understand the case, and then design the prescription of glasses that helps the improvement in vision, also to prevent amblyopia in these cases.